This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
There's data that demonstrates that up to 75% of primary care visits can include a mental health or behavioral health component. And that can include anything from disease management that stresses you out. It can be a true mental health issue, depression, anxiety. It can be substance use, which could include smoking or tobacco. It's also the impact of stress or diet. All of those aspects of behavioral health certainly show up in the primary care landscape, and we'd be remiss if we didn't talk about behavioral health in the context of primary care.
Hello, and welcome to Sg2 Perspectives. I'm your host, Tori Richie. Today, I am so excited to have a host of guests on the podcast. We are going to focus on primary care, cushioning it in the context of the Impact of Change forecast, which will be released later this May. I am joined by our experts, Stephanie Snider, Trevor DaRin, and Caleb Bentley. Thank you for joining today. To kick things off, when we think about the Impact of Change forecast and all of the research that goes into that work effort each year, I'm curious, Stephanie, what were some of the primary care trends that were top of mind as you thought through this year's refresh?
For primary care, we typically think of a whole host of things that are unique to primary care. We think about integration across the health system and how it aligns. We certainly think about workforce and care models. That's a question that we get a lot in primary care, and how workforce and care models show up impacts the care that we deliver. We think about clinic optimization and how that translates into utilization. We think about the competitive landscape, how it's shifting, who's disrupting the landscape, who may no longer be disrupting the landscape. We think about MA and the growth that we expect to see over the decade. And then, of course, we think about consumer preferences and what patients are really looking for and how that impacts utilization and demand.
When you consider some of those utilization trends in the forecast for the last couple of years, we've been projecting declines in some of those preventive services. Is that still the case? What's driving those utilization patterns?
The historic data shows some declines, but we're a little bullish about preventative visits because that's where Medicare annual wellness visits fall in our groupings. And growth of Medicare Advantage is going to drive the continuation of those being an important metric that payers are pushing down to providers. Some of the intricacies of Sg2 forecasting, that this is a glimpse into the sausage factory, not the full view, but that's changing. That's a coding and incentive story. Those visits may still have been happening, but now they're going to shift how they're designated, and increasingly, especially for the Medicare population, both MA and in traditional, as traditional moves to more value, they want to be designated as that annual wellness visit. From the forecast perspective, those are going to grow in line with population.
Do you all have any guidance for our members as they think about a patient comes into my primary care office today? What are those downstream services that they're likely to need? One of the top examples that come to mind is behavioral health. How do you think about behavioral health in the context of primary care and ensuring that those patients have access to those services?
That's absolutely something that providers of primary care should be thinking about. There's data that demonstrates that up to 75% of primary care visits can include a mental health or behavioral health component. And that can include anything from disease management that stresses you out. It can be a true mental health issue, depression, anxiety. It can be substance use, which could include smoking or tobacco. It's also the impact of stress or diet. All of those aspects of behavioral health certainly show up in the primary care landscape, and we'd be remiss if we didn't talk about behavioral health in the context of primary care. It's fully integrated in most health systems, and at this point should be integrated in other service lines as well.
Caleb, you worked closely with Stephanie on developing the behavioral health forecast for this year. And as we think about some of those utilization patterns, what are trends that you're seeing, some of the outcomes that you're seeing in those integrated behavioral health and primary care models?
As far as trends go, we see things run across the gambit. We see co-located spaces, maybe somewhere rural, we'll see a virtual hub and they'll telehealth an expert. And we really see systems focusing on what makes sense for their patient population. I've talked to a member recently in a rural area that before a behavioral health patient leaves, they actually set up their device right there on site so that whenever that telehealth visit is to come in the future, it's a more seamless, integrated experience for both those behavioral health, comorbid patients in primary care and just everyone every primary care patient, thinking of that seamless care coordination is really key. And we see that with a lot of our members. We get lots of questions about how do we focus on that secret sauce that is the system of care? How do we emphasize that line that connects all those sites that typically start in primary care? And how do we make that seamless for both behavioral health patients looking to receive two types of care or primary care patients that might be seeing a CV specialist or an ortho specialist? How do we make sure that we're connecting all those dots and making this a seamless experience throughout the system of care, often starting in primary care?
Okay, I love what you just said. And this is a question that's really been keeping me up at night. How do we define primary care? Because the more that I think about it, primary care does not mean the same thing to all different patient segments. Do we need to have a stratification of primary care offerings based on the archetype of the patient, based on who that patient is?
The short answer is yes and maybe. For most organizations, it makes sense to stratify. But I'll tell you, when Trevor and I talk to organizations, frequently we'll say, how do you define primary care? And they don't have an answer. They aren't sure. They see it as a location rather than a service. They're just not sure. To some organizations, it's preventative. To many organizations, it's transactional. To others, it's chronic care. To yet others, it's all three.
Tori, your definition that would probably, if there was a huge survey of members, it's the front door to access other services. It's triage, it's low acuity care. In the best of cases, it's doing some preventative and chronic care management and care coordination. We know how complicated and tough that stuff is. To your question around segmentation, it's the key point that Stephanie and I are often talking about when systems ask big questions about primary care strategy. The biggest challenge and pushback comes in implementation, where medical groups and providers still really struggle when there's different options, resources, pathways for different patient populations. I feel like it's a place where systems are running into the conflict of this is how to make primary care strategy sync up with bigger system strategies, but the implementation is really tough. Most that are doing anything segmented have one segment that they're focused on.
I'm even thinking just the integrated care models, behavioral health being one of them. Caleb, you mentioned integrating cardiovascular services in primary care as well. And when we think about in context of using primary care as a feeder for those downstream procedural visits, I have to imagine that care coordination and connectivity to specialists is a critical component. How do we ensure that we're building out care pathways that meet those patient needs?
That point is paramount, Tori. If you think of the most recent example of Walmart and their exit from healthcare, they had everything that we advise members on all the time. They know what the consumer is looking for. They have a digital infrastructure in place. They have brick and mortar assets across the nation. But the one thing that they lacked was that care coordination. They couldn't connect a patient from point A, Walmart Health, to point B, that specialist, and it fell flat. We see that with VillageMD. Optum's pulled out of their virtual offerings. We see it across the industry, and I think it's a call to action to our members to think about what they're doing, and they don't need to over-engineer anything to make this a viable practice for them. We already are doing this. I don't think we recognize how special that is or how different that is, and that's what differentiates us from all these disruptors in the market that we hear about all the time. It's something that we're expected to do anyway. That's a really important point not to overlook. How do you just do what you're expected to do really well? And is that enough? Is that the secret right there?
I do think it's funny with some of the recent disruptor activity, them coming to terms with healthcare is hard. It's this concept that these companies that have never dealt with health in any way or caring for a specific population think that they can enter the market and not only excel, but drive revenue, steal market share from longstanding providers. And while that might happen for a select subset of these disruptors, and while that might occur for a short period of time, unless you have that care coordination, it's very difficult to scale and be successful long term. If we have this disruption among disruptors who have, over the last couple of years, absorbed some of that more transactional primary care, what does that mean for the patients that are just left in the dust, that have pulled out of a traditional patient panel?
It's a fair question. Whenever we thought about transactional, it's the place where there's the most change in where consumers are choosing to get that care. We saw it happen really quickly in terms of patients moving to virtual options for super low acuity stuff like ear infections. It's a demand-based forecast. It's not so much that there's going to be a crazy forecast for any of these transactional diseases. It's just changing where they're getting provided. Ultimately, you don't see in the forecast these really radical numbers for any of the transactional stuff because it's not the demand side that's being impacted. It's the supply and the option side. At the same time, we saw higher utilization, and because virtual is making access easier for some things, we're always looking back and trying to pull those trends forward. And there are places where, yeah, there is a lot of growth in those areas because access opened up. But they're not some of our craziest growth stories or places where just because the market's changing a lot, it's reflected in the forecast.
It's an important consideration in that if you reduce supply to those low acuity services, what does that mean then for downstream ED utilization, which then leads to increases in OBS days, inpatient discharges, and the like? It's really easy to deprioritize those transactional patients or the patients that seek those preventive services because they're not translating right now to a downstream procedural volume. But if we don't manage their conditions while they're low acuity, then we're setting ourselves up to see this uptick in higher acuity utilization downstream.
Tori, that's been the story in behavioral health for decades, but it's coming true for all of medicine. At this point, if you're not a health system who's being super proactive about thinking forward and how are we going to start to decant those inpatient beds or be proactive, we as health systems are going to be in a world of hurt in a couple of years. And it largely has to just do with that older population just becoming an immense portion of the total population. The reality is older folks need more care and use more inpatient days and beds. And if there's more of them, it's going to clog our system. Coupled with the mass exodus of healthcare professionals that have occurred over the last couple of years, circling back to mental health, they're just mentally exhausted. That's not going to help with our bed shortage problem. And so we have this multifaceted problem that's going to come to a head in a couple of years. We're just thinking about it now, but we're going to start to see it come to real life in a couple of years.
And I'm curious because Stephanie and Caleb, you all eat, sleep, and breathe the behavioral health service line every day. Because this is something that has so severely impacted the behavioral health population over the years in terms of supply just simply not being there to meet demand, are there any lessons that can be gleaned from building out additional behavioral health access or caring for that patient population in a very supply-constrained environment that can be applied to this medical population that's experiencing similar constraint issues?
The biggest lesson we can learn from behavioral health is to think outside the box. In behavioral health, what happened was we didn't have a workforce shortage issue. We had a care mismatch. The way we were delivering care and the type and amount of workforce we had didn't sync up. That's not a shortage. That's a mismatch. As we start to see similar things happen in primary care, we don't have enough primary care providers. So we can use the lesson of behavioral health that we have to think outside the box. We have to think who else other than an MD can provide the care. MDs are super great. They're smart, they're helpful, but so are other folks. They can lead some of this work too. And perhaps it makes sense to take those MDs, whether it's behavioral health or primary care, and leverage them at the super top of their license to oversee some of the mid-level providers, the APPs, APRNs, and what you will. That's one of the biggest lessons that have come out of behavioral health that can be applied to other service lines.
Another lesson that we see in behavioral health that can be applied in definitely in primary care, but not limited to other service lines as well, is looking outside what you have to offer as a health system. You can't be everything to all people. Behavioral health is a great example of looking in the community, finding those partnerships, and focusing on prevention or focusing on new strategies that just make sure that patients don't have to come to the hospital in the first place. Maybe a little more difficult for primary care, but definitely an opportunity to understand who in your community can maybe help you with these volumes in the future.
There's the non-system virtual providers, and that's a lot of billable stuff. We saw that grow a lot. Some of it's coming back to earth. But the way systems are going to use virtual and build digital ways to interact with patients, a lot of that's not going to be billable. It is going to shift transactional stuff, things that had traditionally driven visits, and who are making those interactions. Even though our overall virtual visit forecast isn't super aggressive, that hasn't changed our outlook on how much systems need to think about digital transformation. Each trend I've talked through, it's been like, well, here's the trend, but here's why the numbers in the primary care forecast don't crystal clearly show the sync up with that trend.
That's an important point in that the virtual strategy is not necessarily a supply strategy. It is an access strategy. It's how do you get services in the hands of people, literally, when they need those services, when they need to be able to access them. And when we think about the spectrum of complexity that patients fall on, if you fall on the end of you require a preventive or just purely transactional encounter, well, you're probably then in a position where you can flip to virtual a whole lot more easily than if you fall into the chronic care bucket or somebody that's a bit more complex that needs to go into a brick and mortar setting. And Stephanie, I think that ties back to how do we ensure that we're getting folks to work at the top of their license? And if you can deploy a virtual model or an AI-enabled model to help manage patients when they really just need to come in and make sure they check the box for their annual cholesterol check versus you need somebody to come in and make sure that their stage 3 lung cancer hasn't progressed. It's a very different deployment of resources.
This gets back to your earlier point, which is so critical. Healthcare is really hard. It's hard because of the differences among patients, the differences among geography, the differences among workforce. When we have outside entities such as Walmart or CVS or whatever trying to come in, they start to realize that. And they realize this piece of the financial pie that is the American healthcare system is not as easy to grab as they think it is, unless you're a disruptor who really understands what patients want and how to deliver it in a financially fiscal way. Others will fall to the wayside. I don't think this is a one-off. Other organizations who just saw the cash cow that is healthcare, many will crumble over the years because it's just not going to be financially viable. Bringing that back to our topic, primary care sometimes is that. It's that questionable part of the healthcare system where we get questions to the downstream feeder. Is this helping our healthcare system? Is it feeding the specialty referrals the way we want it to? Because that's where the margin really is. That's the heart of what many organizations ask us.
Stephanie, that gives us our perfect closer here in that primary care is very complicated, as is the rest of providing coordinated and continuous care to our patient population. And certainly not a mystery that we're going to solve in a single podcast, but always just so fun to get to talk with experts like yourself to keep pushing the envelope here. Stephanie, Trevor, Caleb, thank you so much for joining today and hope to have you on a future podcast soon.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and/or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at Sg2 Perspectives at sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.